I'm very pleased to introduce Dr. Robinson. Tom and I have become colleagues and friends, working with him over the years through our shared passion for optimizing surgical outcomes in older women. Tom is a surgeon who focuses his professional efforts on improving the care of older adults in the perioperative setting. He went to undergrad at Stanford, medical school at Columbia. He did a surgical residency and fellowship in minimally invasive surgery at the University of Colorado Health Services Center, where he's now professor of surgery at UCSOM and chief of surgery at Rocky Mountain VA Medical Center. He is also associate program director for the general surgery residency. As a surgeon investigator, Tom focuses on three major areas, including postoperative delirium, frailty's relationship to surgical outcomes, and national quality initiatives in geriatric surgery. He has published several papers, including the landmark paper describing the preoperative frailty score, which he has developed and has been shown to be predictive of postoperative complications across surgical specialties. He is here today, and I'm thrilled that he's here today to discuss strategies for optimization of surgical outcomes in the older adult. Thanks again, Tom, for agreeing to be here today with us.
No, thank you for the invite. It's an honor to be here, and I really appreciate the interest in older adults. And I appreciate everything you've done, Holly, for older adults. Your center being one of the beta pilot centers, really a pioneering center for the American College of Surgeons Geriatric Surgery Verification Program. I've got about 40 minutes of presentation, and it's going to come in four major sort of categories. I first just want to wish everybody, I hope everybody's safe with COVID and doing fine with COVID. I literally just raced out of the operating room and like took off my N95 to make it here, but I'm sure you're doing the same thing I am. But I like, these are interesting times, and I wish everybody safety and wellness getting through these times. And sometimes it feels like in the middle of COVID, what are we doing talking about older adults? But older adults really are the most vulnerable population that we operate on. And so I do think it's really relevant, even in this sort of pandemic times. And so I'm going to do four like 10-minute sound bites here. The first is just why are older adults different? And so we're going to try to understand what a geriatric syndrome is and why that's relevant. Then we're really going to go into how to optimize the care of the older adult. We're going to do a quick frailty 101, how we measure the frail state, how we conceptualize the frail state. We're going to learn how to establish goals of care, because I think that if we can understand goals of care, we can make enormous progress towards improving the care of older adults. That's probably one of the areas that's overlooked. But if we can optimize that, you can prevent a lot of unnecessary operations and unnecessary postoperative morbidity. And then finally, the lowest hanging fruit on the quality tree is delirium. I think delirium is under-recognized by the surgical community. And if we can recognize and prevent it, that's the #1 quality initiative that I'd recommend that you do at your place. So let's get going. And so the first section here, so it's going to be 8 to 10 minutes, each one of these. It's just that, like, why are older adults different? And so as I just emerged from the operating room, I'm very like disease focused, right? As a surgeon, I'm a general surgeon, and the gynecology team on the phone, right? You're looking at pelvic floor disorder, or you're looking at very specific disease processes. And that ultimately has what's made modern healthcare so successful. But the issue about older adults is they develop these special syndromes, these clinical presentations called geriatric syndromes. And we're going to try to understand what those are. I've listed 5 of them here in this circle around: delirium, function, like impaired function, falling, so something with mobility, development of pressure ulcers, and poor nutrition. So the older adult is specifically vulnerable to geriatric syndromes, whereas a 50-year-old adult really wouldn't be predisposed to these syndromes at all. And that is the unique difference. And so I'm going to try to sort of in 4 minutes, and I don't want to lose you here, but I think it's really, this is the core concept of geriatric medicine. So it was initially described by it's Sir Isaacson, who was knighted at one point, but this was a geriatrician in Bristol, England. This was in the 50s. And he was seeing all the older adults in Bristol. And what he figured out was that before older adults died, they developed four symptoms. And these are the geriatric syndromes. They're known as the giants of geriatrics: falls, incontinence, delirium, and immobility. And so this geriatrician was practicing in Bristol, England, and he noticed that, even if somebody came in, say, having a myocardial infarction, they would actually present with delirium, one of these four kind of cornerstones of clinical symptoms that occur in the last year of patients' lives. And so let's just dive in for a second here. And again, I don't want people's eyes to roll into the back of their head at the start of this, but if you can come away kind of embracing that older adults have these unique clinical presentations, I think we're moving in the right direction. So here's a modern list of geriatric syndromes. Dr. Isaacs had the giants of geriatrics, which was 4, but frailty was recognized in 2002, 2003 as one of the geriatric syndromes. We already went over delirium, falls, functional decline. Depression, and I'd really say rather than depression, probably loneliness, the social isolation piece, poor nutrition, pressure ulcers, urinary incontinence, syncope, and dizziness. And so let's try to understand, these next 2 sentences are kind of big sentences, but then I go over it with some figures to follow and to try to really grasp what it means to have a geriatric syndrome. And so let's just look at these for a second. And I want to sort of I know we're starting with kind of dense material to try to understand, but I really think geriatric syndromes, it's the core concept of geriatrics. So a geriatric syndrome represents clinical symptoms of older adults, which are the consequence of which are not the consequence of a discrete disease category. So an example I would use in the gynecology world would imagine if an older adult, an 85-year-old, came in with a urinary tract infection, and so they had localized UTI, a cystitis, which should cause suprapubic pain, right? And then they maybe have some systemic sepsis or something from that. That patient, rather than presenting with suprapubic pain or dysuria or burning with urination, they actually present with, the most classic one again is delirium, right? So delirium is that geriatric syndrome. It's not actually, it's discrete. So it's separate from the disease, which is urinary tract infection or cystitis at that point. So let's read this second sentence, and then we're going to do a couple figures to try to understand this. So the second one gets really at the core of it. So the presentation of a geriatric syndrome is the result of physiologic compromise across multiple systems, which result in a clinical symptom that's completely distinct from these subclinical physiologic impairments themselves. So that's a huge mouthful. And so I've got an image that tries to capture that statement next. So here's the image. Ultimately, the geriatric syndrome is the patient's fall. So if you start in your clinic asking patients 80 years and older, hey, how many times have you fallen in the last 6 months? It turns out a lot of them will say, oh, I fall every few weeks, or I fall every couple months, these outpatient falls. And if you think about it, I'm not sure who's on the phone. I can't see everybody else on the Zoom line here. You probably haven't fallen at all. And this is really different. So falls are geriatric syndrome. And what does a fall result from? Well, it's multiple impairments across multiple systems that lead to imbalance and then falling. So neurologically, there's altered proprioception. Sensory, there's impaired balance, diminished vision. Motor, the muscles are a little weak and they're slow to respond. Mobility, there's unsteady gait and an altered stride. And you take one of those and the patient's not going to fall, but you put all of these sort of small physiologic decrements across all these systems, and then the result of that is a fall. That's a geriatric syndrome. The last slide I have trying to understand geriatric syndromes is, again, getting at this concept that we have multiple systems that typically work in harmony, and all of a sudden, as you become a frail older adult, those systems don't sync and they don't work in a uniform way. So healthy adults maintain complexity because across multiple systems, the neurologic system, the motor system, the sensory system, they're all working in harmony. And when you have a healthcare stressor, the organism or the human body is able to withstand that. But for older adults, where all of a sudden there's decrements in these physiologic systems, that makes the person unable to handle a healthcare stressor, and how they present is with a fall or with delirium, one of these geriatric syndromes. So again, the final slide of this section is simply, and we're going to move on to less dense, more fun stuff, I promise you. But we need to, like the United States healthcare community needs to move in older adults from this disease focus, right, where we're focused on that center circle, to this balance of care for that 80, 85-year-old, where we say, okay, certainly we need to focus on the gynecologic problem, on the tumor, the malignancy, the pelvic floor disorder, so while we need to focus on that, but we also need to recognize that there's these syndromes, these geriatric syndromes that are extremely common in this population. And while we're focusing on that disease in the middle, the center of the circle, we also need to be maintaining function, preventing delirium. We need to be optimizing nutrition because these folks are so vulnerable to the geriatric syndromes. So that's the why. And I would say that at the University of Alabama, you're really one of the pioneers, being a beta pilot site, because the geriatric surgery verification program that's sponsored by the American College of Surgeons, what that's up to is this circle, this supportive care that surrounds the underlying disease process. And whether that disease is an orthopedic problem, a gynecologic problem, a surgical oncology problem, it doesn't matter. This outside ring stays the same for the frail older adult. Okay, so that's enough that's like the big sort of why are we doing this section. So let's spend 10 minutes on frailty. As we go through the phases of care from pre-op to post-op, we need to recognize who the frail older adult is. And I'd imagine that the team on the phone is mostly doing elective operations. And so I put in, like, up front, we need to be doing, prior to the operation, our geriatric vulnerability screens, which instead of vulnerability, we could use the term frailty. Then we need to actually be saying, okay, if the individual is frail, we need to be targeting an intervention towards that characteristic that makes them frail. And then we need to be running them through the remainder of that pre-op process, whether it's be communicating with their primary care. And I'm not sure if you still have your interdisciplinary high-risk conference at this point from the beta pilot. But I think that this Paula got it wrong. Paula's, she's the Paula Spahn is the New York Times aging health writer. And it's not one last question before the operation, just how frail are you? That's the first question we should be at. Right as we're evaluating the disease process, we should also be saying, how frail are you? Because that's going to help us understand what supportive measures we need to put around this patient to get them through this healthcare episode, this surgical episode that we're going to offer them safely and in an optimal way. All right, so let's conceptualize frailty. There's biologic frailty, which outside of Baltimore, very few, although it's interesting, Holly, I noticed that your group did use phenotypic frailty in one of your studies. But biologic frailty, essentially, that's on the left side of this slide. It takes 5 clinical factors: physical activity, fatigue, muscle strength, which is done through grip strength, energy level, speed of walking or gait speed, and then shrinking, which is weight loss. And they actually say that there's something in the cell biology, and the cornerstone of phenotypic frailty is sarcopenia, or loss of muscle. And they actually say there's something being driven from the cells that create these clinical characteristics or these symptoms. In contrast, outside of Baltimore and outside of maybe a few research studies, the absolute rest of the healthcare community uses the deficit accumulation frailty model. And that's what I would kind of encourage you to take on. So this is championed by Ken Rockwood. So you notice the arrows here are pointing out. So the cells, something inside the cells are driving these, where it's the exact opposite here. It's the clinical characteristics like multimorbidity that's causing the deficit that then makes the patient physiologically vulnerable. The patient has impaired function, impaired activity of daily living. That's creating deficits. Poor nutrition creates deficit. Social isolation and vulnerability creates deficits. And when you accumulate a high number of these deficits, the patient is then triggered as frail. I sometimes, so these two groups, it's like, they're not necessarily like warring tribes, but they don't necessarily agree. So sometimes it's more a little bit, I would say, politically correct to say conceptualizing vulnerability, because the phenotypic frailty folks got in the game first, and then they kind of think frailty should be reserved for the biologic frail state. And that Ken Rockwood's this deficit accumulation should be more vulnerability than frailty. I think it's semantics, and I don't think you have to worry about that too much. You can call this frailty, most people do, but if we're really digging into it, maybe we should be calling that vulnerability. So let's look at just the characteristics we should be using in our frail score. So I would encourage you in your group, if we're going to optimize the care of older adults, we need to be identifying the frail older adult right up front before the surgeon's going to make their decision whether or not they're going to operate, because you want to know what kind of burden of positive frailty characteristics the older adult has. And so in your clinic, you should be screening, and I'll show you there's a few tools we can use, but you should be screening for the frail older adult. And these are the characteristics: function, mobility. For mobility, while we can be doing stuff like gait speeds and timed up and go, we can also just be simply asking them, have you fallen in the last 6 months? You know, you can do stuff that's very concise and short, or you can do more comprehensive assessments. Looking at cognition, the mini-cog is probably the most common one that folks use. Looking for nutrition. So we can do nutritional studies and stuff, but we can also just be asking, hey, have you lost 10 pounds or 10% of your body weight in the last 6 months? You know, that would be more a NSQIP, the National Surgical Quality Improvement Program uses those definitions. Social isolation is one, multimorbidity or burden of chronic disease, and finally polypharmacy. There's a number of other characteristics that you can use. I kind of picked the bigger ones. The notable one I always recognize it's missing is depression or loneliness. Well, it's not formal like DSM, major depression. Older adults suffer from loneliness. And I think that's one of the characteristics in the accumulation and deficit model of the frail older adult that we should recognize is out there. And you may or may not include it in your group. I have this, I always tell groups that I call it the big five. And I don't know if anybody's ever been on safari in Africa, but they talk about the big five. Like, you know, have you seen the elephant, the cheetah? I think you got to include the big five. If you're going to do the accumulation and deficit strategy, which is by far and away the most common, the big five are function, mobility, cognition, nutrition, and multimorbidity. Probably should be including those. And depending what kind of operation you're doing, we can emphasize some characteristics and de-emphasize other characteristics. But the big five, here they are. So let's look at these on a frail scale. So we're going to take an older adult woman who's coming in, who's going to have a major sort of 3-hour abdominal hysterectomy, so a major operation. And we're going to say we're going to measure these 5 characteristics here. What we're going to do is we're going to put them on a frail scale. And what a frail scale is a scale of risk. And so you're going to take those characteristics like building blocks. And if it's a normal characteristics, so if you screen for nutrition and they have normal nutrition, the block's going to go on this side of the scale and weight towards average outcomes. But if they have malnutrition, so they've lost more than 10 pounds of weight in the last 6 months, the block's going to go on the poor outcome side. It's going to weight the scale towards poor outcomes. And so let's just weight the scale. So, right, if the majority of your frail characteristics, they haven't had geriatric syndromes, they have regular walking speed, or they haven't fallen, they have a low burden of chronic disease, so no multimorbidity. Albumin is a marker of nutrition is up here, right? If the majority of what you test are normal, the scale is going to weight towards average outcomes. In contrast, if the majority of characteristics are abnormal or they trigger positive, then it's going to weight the scale towards poor outcomes. And so this is the kind of information that the surgeon's going to need right as we're going into that patient, talking to the patient, discussing their healthcare goals, and trying to make the best decision on how to move forward. So, right, this isn't something where you make the decision to go to the operating room, you consent them, then you do the frail assessment, right? Because then you can't actually trigger any change in care based on that. I'm going to show you a figure from our group, but there's no reason I would show you our group versus other groups. Based on the number of abnormal frailty characteristics, the non-frail is 0 to 1 abnormal characteristics. The pre-frail is 2 to 3. And then the frail group has 4 more abnormal characteristics. So that frail group is when all those blocks are weighted on the abnormal side, and so they weight towards poor outcomes. You can see there's an absolute ordinal response, and this was our slide on one or more major complications. But this same ordinal response, not when you look at 30-day mortality, but when you look at 1-year mortality, it's the exact same. The percentages are much lower, but there's this ordinal lowest 1-year mortality in the non-frail group to the highest in the frail group. And it's the same despite whatever kind of operations, whether we're doing hysterectomies or whether we're doing thoracic lobectomies. The surgical stress isn't what matters, it's the intrinsic vulnerability of that patient, which is key. There are more than 70 frail tools out there. And you're like, I just want one, give me the frail tool. And I'm going to suggest to you that I sort of threw a bunch of the frail toolbox on the screen here. The NIH has a nice toolbox with all the resources to implement frail screening. And I would suggest to you that there's no one frail tool that fits for all needs. And, as a gynecology service, certainly you're doing major operations. And so you're probably creating impaired function. So you may want to look at function. You're probably creating ileuses after the operation. So maybe nutrition is going to be emphasized more in yours. Whereas others like orthopedics, who's more interested in the mobility and they may want to choose a different one. But what you need to do is take the population that you're operating on and then take a tool that kind of fits the characteristics, fits the unique needs of those patients. And the second thing I would say, and this is probably the one that people focus on the most, is they want to do something quick. And so depending on your resources in clinic, right? So the Edmonton Frail Scale, which is this one in the middle of the screen here, probably they say you can do it in 15 minutes. I can't do it in 15 minutes, but 20 minutes. It's a lot of hands-on, gait speed, all this kind of stuff. Very, very nice, comprehensive, but it takes a lot more resources to do, right? Because it takes time and it takes having either a nurse or a medical assistant who's going to as they take the vital signs for the patient, actually doing that. You can do much quicker up in the upper left here under table 3 here. That's the frail scale. So that's 5 questions. And then you just have the scoring of non-frail, pre-frail, and then frail. That's the quickest one that I know about. Never been validated in surgical patients that I know. But again, it's getting at these core characteristics of the vulnerable older adult. So let's look at the gynecology literature and frailty here for a minute. And this is Holly and your group is working on this. And they're taking actually the same characteristics that we used here in Denver. And again, so this is the accumulation and deficit model of trying to measure the frail older adult, where we're looking at cognition, function, multimorbidity, mobility, and here we used falls, burden of chronic disease by anemia, actually, and albumin. And then following these patients after pelvic floor, after prolapse surgery, 6 weeks for outcomes. And it is interesting, we're going to get into goals of care next. But older adults sometimes aren't always as concerned with, at the top here, you can see there's a composite outcome of one or more severe complications. But sometimes they're more interested in where they're being discharged to. Are they going to be able to return to independent living, which is down here listed under the geriatric complications. And it is interesting. I love the fact, Holly, that you included falls. We, as part of our geriatric program, call all of our inpatients after discharge. And you cannot imagine, almost 1 in 5 of them have fallen in the 2 weeks between their discharge and when we call them, right? And this is that geriatric syndrome, those multiple small decrements across physiologic systems that ultimately leads to the symptom of a fall. It actually is just blowing our minds here. And so we're actually sending extra physical therapy, even if folks don't think they need it, because we're seeing so much of that in our group. And the final long-term outcomes that are being measured, again, is whether or not people are living independently, whether or not they're in nursing homes. And then there's disease-centric stuff, also recurrent prolapse. And then the final slide I have for the frail is simply, I looked very hard, and maybe you can teach me. I couldn't find that there's a difference in frailty between genders, between male and female genders. And so this was a study that's published in 2020 here. The absolute numbers of the women in the study were higher, but there was no statistical difference in the clinical frail scores between men and women. And because I was thinking coming into this talk, I'm not an expert in the difference in genders, but I do have a pretty good handle on the frail state and conceptualizing and measuring it. And I was thinking that there was going to be differences in gender. I couldn't find that in the literature, and I'll be interested in the conversation at the end here, what folks know. So, and you're thinking to yourself, well, like, okay, we're going to measure this, but like, how are we going to optimize care? Because there's always like, if somebody's frail, you can counsel them differently. And like, certainly that is true, because the frail state, right? If somebody's frail before surgery, we almost know they're going to go to, particularly after major surgery, they're going to go to a nursing home or a skilled nursing facility afterwards, right? They're not going to be able to return home because one of the geriatric syndromes is declined function, and they're going to be deconditioned. And so we know actually, and here we actually implement physical therapy beforehand. We have our counselors already working with them beforehand. But I think the approach that we're really trying to emphasize right now at our place is we're actually trying to optimize them rather than just saying we're going to counsel you. It's going to be, the outcomes are going to be poor. And so if you look straight across on these, right, so if they show like dependence in one or more activity of daily living, our occupational therapists are seeing them at least once before surgery. Now we're kind of with COVID, we're kind of doing it over the phone. I don't know how that's going to affect us, but so if they have poor mobility or falls, physical therapy sees them. Impaired cognition, there's not a whole lot you can do to improve somebody's brain function beforehand, but the delirium pathway is the prevention pathway. We're going to talk about that here, is clicked right out of the gates. Poor nutrition, we have our nutrition folks see them, and we actually ship them supplements. Social isolation, we do the discharge planning. Burden of chronic disease, geriatrics actually sees these if you have multimorbidity. And then finally, polypharmacy, the pharmacist helps us, and we trigger that if there's a Beers medication or greater than 10 meds on the chart. But in other words, you want to be actively trying to optimize the older adult. All right, so I'm going to speed up on the last two so that we end in 15 minutes and have questions. So the next is goals of care. You know, it's a real paradigm shift. I think like when I started, at least, I've been practicing not quite 20 years, but almost 20 years. And consents were very disease centric, right? We're going to take out the colon. There's a certain risk of infection and, you know, certain risk of whatever wound disruption. And I think that what I'm really moving towards is a more patient centric and trying to evaluate what a patient values. And this is really a remarkable statement over here, is that 70% of older adults would choose a treatment that causes, would not choose a treatment that causes severe functional disability, even if survival was assured. So in the next few minutes, I want to try to distinguish and define the difference between health span and lifespan. And so if in this goals of care section, we can get at what the difference of health span and lifespan is, that's the goal of this 5 minutes. Okay, so lifespan is the total number of chronologic years an individual lives. And I think traditionally, this is what, like, cancer surgeons, you know, if you're treating a gynecologic malignancy, it's about survival, right? Whereas health span is the time in one's life during which an individual is healthy. They have wellness, whether that be living independently, you know, how the patients define wellness may be different. So I have a graph that I'm going to kind of construct out here. And so we have health span on the x-axis, and on the y-axis, we have on the x-axis lifespan. So this is the threshold, the function threshold, and function can be brain function, physical function. You know, function can be any kind of function, but you can see above this we have vitality, active life, independent living, and below this we have dependent living, inactive life, and the frail state. And so we have baseline health, and then we have you as the surgeon making this decision. I'm going to say it's a gynecologic malignancy. So we're going to proceed with a total abdominal hysterectomy, or we're going to do a different set of care. So if we proceed to the operation, you can see big surgery, say a 4-hour operation, blood loss, what have you. Patient gets very deconditioned during their hospital stay, but they tend to, like the frail patients, don't die in the operating room, right? That's not the consequence. They leave the hospital, probably though to a SNF or a nursing home, right? Some of them may get back above the functional threshold, but then they peter out and they die here so we operated on them at 84 and a half years and they lived to almost 86 years. In contrast, if we take a medical oncology approach or a radiation therapy approach, I don't know specifically for gynecologic malignancies, right? But if we don't do that major operation, what's going to happen is the patient's going to maintain their function and their vitality, very similar to where they were pre-op, right? Because you didn't do it, but their oncology, their medicines or their radiation may cause detriments, but then they're going to taper off and they're going to die sooner. And so what I want to point out to you is this is health span, right? So the individual who chose the natural history or the medical management of their disease maintains wellness for a longer time, but they decrease their total lifespan. So they live a shorter amount of time, but they have vitality and wellness for a longer amount of time because they didn't get this big operation that deconditioned them and pushed them below that line. And what the literature is suggesting is that if you really talk to a lot of older adults, what they want to optimize is number 2. And now certainly everybody wants to live the longest, but these studies and they're really, it's kind of remarkable because it's a total shift in paradigm about how you consent people. It's not all about survival. It's about how long people maintain wellness. So that is health span. There's lots of different strategies out there about how to do good surgical decision making. I'm not necessarily a proponent or one or another. My goal is to try to sort of push out there that there's this concept of health span and that we shouldn't all just be focused on lifespan, and whether you use best case, worst case, or there's a nice guideline statement for best communication practices. How you do it, I think, can be variable. But I do think emphasizing health span is going to be critical moving forward to making good surgical decisions. Final section, and we have just about 10 minutes left here, so we'll end right on time. So if we start looking into, so for the first time, I'm moving into the post-operative phase of care. And when you look at the post-operative phase of care, we need to be all about focusing directly on preventing the occurrence of geriatric syndromes. The geriatric syndromes here are delirium, impaired function, and poor nutrition, right? When you're managing their medications and all this stuff. But I want you to think to yourself, what is the number one complication in the post-operative setting for inpatients? And you're thinking to yourself, is it infection? Is it myocardial infarction? Is it cardiopulmonary stuff? The number one post-operative complication in older adults is delirium. And it's not even close, it's 5-fold. So this is, Holly mentioned this in the introduction, but in 2014, we had about 25 hospitals across North America, and we started collecting as part of NSQIP, the National Surgery Quality Improvement Program, unique variables to older adults, like the geriatric syndromes, frankly, exactly the geriatric syndromes. And delirium was one of them. And you can see that when you looked at everybody 65 and older, this was in about 60,000 patients, the occurrence of delirium was 5-fold any of the other complications that were reported. Delirium is a synonym for it would be confusion. So it's acute brain dysfunction in the postoperative setting. When you go into major operations, the incidence of delirium can be as much as 1 in 2 or 50%. So that would be like in the ICU. And delirium is so important because it is closely tied to whether it be major complications, death both in the hospital and 6-month death, these other geriatric syndromes like functional decline, but then the kind of the C-suite, which what's a better word for that, but hospital administration is very interested in in hospital length of stay and healthcare costs, and delirium is very closely associated with with increased costs. And so if you think about what's unique about delirium is it's preventable. So 1 in 3 cases of delirium is preventable by simple bedside measures that I'm going to sort of supportive measures, supportive interventions that the nursing teams do. So I want to promote to you that delirium is the absolute perfect candidate for a quality improvement project. And I can't tell who's on the phone, but typically I try to recruit a resident or a fellow to try to do a delirium prevention project, particularly in the group that's getting major operations. It's the perfect quality project because it's common, so it's the most common problem. It's deleterious, it's associated with really poor outcomes, and it's modifiable, so we can prevent 1/3 of cases. All right, so we're going to go to the American Geriatric Society's statement. They have a strong recommendation, this is in the postoperative delirium guidelines, that healthcare systems and hospitals should implement multi-component non-pharmacologic intervention programs delivered by an interdisciplinary team for the entire hospitalization in at-risk older adults undergoing surgery to prevent delirium. So when you're doing major pelvic operations on the gynecology team on patients, we choose 70 years and older, but you pick a threshold. It could be 65 and older is what your study group is. You should be implementing this multi-component non-pharmacologic intervention. So what does that look like? I'm going to show you the landmark paper on it, which has 6 interventions. And so what they did, this is Sharon Inouye's group, they took patients on 2 different inpatient wards. They were medical wards, not surgical wards, but I'm going to show you in a minute how to tailor this to surgical patients because I do think our patients are different than medical patients. So these were the 6 risk factors on the left-hand side that they addressed. So for cognitive impairment, they simply oriented the patient to person, place, and time 3 times daily. They chose inpatients 7 years and older. Sleep deprivation. They did sleep enhancement, so they didn't wake people up in the middle of the night for vital signs. They kept noises on the units down so that they wouldn't, disrupt somebody's sleep like an alarm clock from noise from beepers or buzzers. For immobility, they walked patients in the hall a minimum of 3 times daily. They had early vision and hearing protocols. I think the old classic way to do it for hospitals was they didn't want to lose patients' glasses, so they would keep them in a special place. But the idea is that you want patients' vision not to be blurry the whole time they're in the hospital, and you want them to be able to hear. So very proactive vision and hearing protocols. Final thing they focused on was hydration. I think that's not as relevant to your group, right? As surgeons, I think we're more in tune to ins and outs and the hydration status of our patients. And basically what they found is they reduced the incidence of delirium by 1/3. So they reduced delirium from 15% to 10%. Total days of delirium in the group was less if you did these bedside maneuvers. And finally, the total number of episodes of delirium was less, from 90 to 62. I would encourage you, and maybe you already have one, most groups don't. And I'll be curious to see how you're doing along your journey towards improving the care of older adults. Here's ours. I would tell you it took me 8 months to negotiate this. And right, I have a slide here about how to negotiate, how to identify your stakeholders. But you think, well, what takes 8 months to do? But right, you have to actually, because you're not doing this, you're just clicking an electronic medical record order set that says, this is the bundle we're going to do. It's actually the nurses at the bedside and the physical therapists, if you have an activity program, who are going to be doing this bedside. So you got to get your stakeholders to agree. But you can see, ultimately, what we agreed upon was this is sleep hygiene, right? Trying to let people sleep at night. So we try to actually keep them awake during the day, open the curtains and the windows so the light comes in, let them sleep at night, and we don't disrupt them. We hold vitals between 10 p.m. and 5 a.m. on the wards. We're ambulating in the hall, minimum of 3 times daily. You can see that's right out in the New England Journal article. Promoting sleep hygiene again, large clocks and calendars, reorientation of person, place, and time. Assure patient has sensory aids, so hearing and glasses. Preferentially assign rooms to windows. We've moved to a newer hospital, so all our rooms have windows, but that is an important, we used to do that at the old facility. And then the other thing we do that wasn't on that, but we really try to get the family members in at the bedside and even staying at the bedside overnight to help orient the patient. Here's a list of supportive interventions that I think are important to the surgical patient. And the ones that I specifically want to point out, and I'm actually going to have a slide on, is pain management, right? So you create a surgical incision and you cause pain. Uncontrolled pain independently causes delirium. And so if we can have a good pain protocol, so I'm just going to review just in generic terms what a good pain protocol would be for older adults. And the other one that I think is really important is appropriate medication usage. If we're using the wrong medications, boy, we can cause delirium, and what we should be doing is trying to reduce delirium. We should be doing the exact same opposite thing. So this is the medicine mnemonic. I don't particularly like this because, you know, this is for somebody like coming into the emergency room. Like, it's very uncommon in the hospital to like have hypoxia cause it, or have low sodium where we're checking these things every day. In our group, 75% of the folks that had an underlying cause of delirium was infection. So in other words, they get an infection, they get delirium, and it is fairly remarkable. Post-operative delirium happens most commonly on post-op day 2, but there's a bimodal distribution. On a post-op day 5, 6, when the infections start, you get another spike of delirium in that group. Medications also in our group, we had inappropriate medication prescriptions, most notably Benadryl. And I'll bet you should look at your PCA. I'll bet you Benadryl is bundled in your PCA, or a resident using Benadryl as a sleeper. And then finally, pain. So we definitely had a list that's unique from the medical list. So here's our here's a list of meds that are from the Beers list of medications. The Beers list is really a globally recognized list. Dr. Beers was a physician at Harvard, and he made this list of medications that are more likely to cause adverse events in older adults. And I've just tailored it down. When you read the article, it's like pages and pages of medicines, but it's mostly like psychiatric medicines, Parkinson's meds, and I boiled it down to the ones that are given, I think, in the perioperative setting that you would be most likely to give. So you can see there's a group of pain medicines that we should be avoiding. GI stress ulcer prophylaxis, I would just tell you, for that one specifically, I don't even know that you need, you should really look at who needs GI stress ulcer prophylaxis. It's the major burns, big head injuries, people on ventilators. But a lot of our surgery patients tend just to go on GI stress ulcer prophylaxis when they're on the surgery ward. It's not even indicated, so you probably don't need anything. But if you are going to use something, avoid the cimetidines and ranitidines. Nausea medications have an enormous anticholinergic burden. Benzodiazepines, unless somebody's on them chronically, so they're going to withdraw, we should probably avoid benzos. And then here's the big culprit, is Benadryl. And again, the low-hanging fruit is, I'm curious, I'm going to ask and see if it's on your PCA or if anybody knows. You need to unbundle this from that group of packing, that it's called the prescribing cascade. When you prescribe the PCA, it also automatically prescribes Benadryl for itching, Narcan, and oxygen, right? It's this cascade of other things that you get. And you want to try to minimize the number of meds that the older adults get. A multimodal opioid-sparing pain regimen. This is ours, and so I would encourage, to prevent delirium, to have this as an electronic order set. And it doesn't have to look exactly like this, but the concept is you don't start with the PCA or start with the oxycodone. You don't start with the narcotic. You start with adjuncts. So ice packs is what we use, massage and relaxation. Should be maximizing regional blocks, so working with an anesthesiologist that can provide a regional block, preferably even prior to the incision to decrease the anesthesia load in the operating room. But if not, then after the incision. But regional blocks are really big. Acetaminophen, the American Geriatric Society #1 medication for pain is acetaminophen. I know you can go up to 4 grams, but it's recommended 1 gram 3 times a day. Notice it's TID, not Q8, because you don't want to wake folks up at night, right? You want to let them sleep through the night. Gabapentin is definitely controversial. If somebody has impaired cognition at baseline, probably shouldn't do this, but it's clearly been shown to improve postoperative pain. Then once we go below that, we're reaching down to the narcotics. If we're giving a narcotic, we're always bundling that with a bowel regimen. Non-steroidals are controversial, but I would tell you that the reason non-steroidals are on the Beers medication list is for chronic usage, for like arthritis and stuff. For acute usage, we use non-steroidals here. I'm the one who oversees this, sort of our delirium prevention pathway. And, it's on the Beers list, so there is a little bit of controversy, but when you ask the majority of big geriatric groups, giving it for, say, the first 3 post-operative days, that's fine. It's the chronic use is why it makes the Beers list. This is my last slide before the sum up. To do any quality program right, you have to identify your champions. And I think UAB of anywhere, I always think of Kelly Flood as the ultimate person at implementing hospital programs. And so we should really probably take this from Holly, but right, we need to identify leadership, the surgeons and the nurses. So the gynecologist finds the charge nurse on the ward or an interested in nurse on the ward. You negotiate your delirium prevention bundle set. So you need to get your stakeholders. And we had stakeholders beyond just the nursing team on the floor that's doing that one-on-one interaction at the bedside, because we included physical therapy, occupational therapy, like we included what we thought would be all the stakeholders. We implemented education. For the surgical team, it's mostly educating them where the order set is in the chart. But for the nursing team, right, they actually have to train about how to do these interventions at the bedside. You got to build your order set and then you launch it. And it took us, again, you'd think it's simple, but it took us to do it for patients 70 and older in our hospital about 8 months to kind of run that process. Final slide is there's lots of resources out there that'll help you improve the care of older adults around major inpatient operations that I imagine the gynecology team is doing at UAB. And there's the delirium guidelines that are being updated right now, but really not a lot has changed since 2014. American College of Surgeons has a perioperative management and a preoperative assessment, best practices documents. All these are free online. You just click it, there's a PDF. And then there's the optimal resource guide, which gives the 33 standards of what you should be doing to improve the care of older adults. And section number 5 is the clinical one. So you can really boil it down to probably 12 that you can just kind of look at. It's these right here, the patient care expectations. Super, like, it's very just the nuts and bolts of taking care of older adults, preventing those geriatric syndromes that we looked at the start of the talk. And with that, Holly, I think I'm going to turn it back over to you for any questions. And I do want folks to notice I've got my email down here in the lower right. Please email me if you are interested in delirium or frailty. Like, I make a lot of contacts through talks like this. And if I can help you improve the care of older adults at UAB, reach out. And I'm going to keep my email up in that bottom right corner while we have a conversation.
Tom, thank you so much for that. I think, well, you're kind of preaching to the choir, I'm proud to say, because especially as our experience through the Coalition for Quality in Geriatric Surgery, the beta testing site that we were able to implement many of these power plans and approaches to the care of our older women. And these things are still being maintained. I'm happy to talk further. First, I'd like to reach to the audience to see if anybody has any questions. Please feel free to ask Tom. Tom, I'd let you take care of me any day.
Yeah,
Sure.
but you qualify yet.
I don't qualify yet. I don't qualify yet. Yes, let's make that clear.
So
go ahead.
Ask a question here. So your group looked at people with pelvic floor disorders, and of folks 65 and above, right, 17% you identified as being frail.
That's correct.
And so I think that's really, like, to me, to the group on this phone, that's pretty compelling of 1 in 5 folks that are rolling through. Because I'd imagine most folks are 65 and older, Holly, or not?
I would say the mean age of at least pelvic floor is the bigger operations is probably in the early 60s, for sure. I once talked to Neil Resnick when I was at Pitt giving a talk years ago. And one thing that I had concerns about is doing surgeries, even minimally invasive, say outpatient type surgeries in our patients that are 75, 80 and older. where you would normally send them home if they were 50s, 60s, 40s. What is your sense on how we should be handling these patients? So a woman comes in, she's 80, we do a mid-urethral sling on her. Typically, she goes to post-op, wakes up, we do a voiding trial, she's out the door. Neil Resnick about how to come apart with thinking about that for our older populations. What would be your
And
feeling
what was
on
Neil's
that?
take? He wanted to keep them in the hospital longer?
He wanted to do an overnight, yes, for a procedure that would definitely be considered an outpatient procedure.
You know, I would say that that is controversial.
Yeah.
Because does the hospital cause more harm than good? And I know that on Sandhill Drive, which I don't know if anybody knows, Sandhill Drive is where all the venture capitalists are in Silicon Valley. But there's an enormous venture capitalist effort right now to basically, Holly, take that patient, that vulnerable older adult, and actually send them home, but then send a nurse with them to their home, because you avoid all of that, the stimulation of the hospital, the unfamiliar environment of the hospital. You have the family already at home. And so putting like a provider at their home, because the viewpoint of this foundation is that the hospital has a lot of sort of detrimental side effects for older adults. So I think in an ideal state, but that's obviously a costly initiative, is to actually put healthcare, they wouldn't be RNs, but like medical assistants to aid people at home and sort of bridge them through that first night. But I think that's what's coming, is that I think that it's trying to get people out sooner, but give them support at home so that the vulnerable, frail older adult, you know, has that extra help to kind of move around, transition out of bed, make their food for whatever that time window is. So that's
Okay.
not a specific answer, but I think there's
Right.
a lot of folks talking about that the hospital's not all good. So I would say I kind of weigh against Neil on this one, in the sense
Yeah.
I think I'd be trying to send him home, but give him support at home.
That's a good answer. Any questions by anybody in our
Are people
audience?
stunned out there? Everybody's on mute. Was that too academic, or
No,
is
you kidding?
is everybody shy on Zoom? Anybody?
No.
I'll pick somebody out. Are there residents on the phone?
Oh yeah.
Or fellows?
Yep.
How
Why
about
don't you?
residents or fellows? Because I would tell you, if you want to, particularly if you want to do something in academics, I think the space of perioperative care of older adults has an enormous amount of funding. And I would tell you, has an enormous amount of clinical relevance. And so does anybody think of a project that they could do with older adults that might improve the care, their UAB? Because you're probably halfway as a fellowship, 1 year, Holly.
The pelvic floor and GYN oncology fellowships are 3 years.
Oh, wow.
Yeah.
So you have plenty of time to do a project.
What about, what was I going to ask? It seems like many of the components that you recommend are also current components of the ERAS, perioperative management. Have the ERAS and the geriatricians gotten together kind of on an official basis, or what's your sense there?
You know, I mean, you can quote me on this. I'm not a big ERAS person for older adults. You know,
Okay.
this whole super feeding super early and all this kind of stuff, we've run into a lot of trouble with it. Now, having said that, I think what translates from ERAS to improving the care of older adults is this whole concept of standardized kind of checklist medicine, where everybody's moving along, right? Everybody's being mobilized, having nutritional assessments, preventing delirium, and right, it's protocolized and standardized. I think that's what the geriatric surgery verification program kind of gets from ERAS. But ERAS is all about decreasing length of stay. And in my mind, Holly, and this is going to go a little bit against what I said before, but to increase stay by 1 day and then not have to send somebody to a skilled nursing or a nursing home afterwards and get them home, that's a day that's invested in quality of life. And so I don't like, we at the geriatric surgery verification, sort of that group, we bristle a little bit about that length of stay is the penultimate, reducing length of stay is the penultimate goal. I'm not sure it is for the vulnerable older adult. And I'd be happy to hear anybody else's take on that. But we think they're a little bit too much focused on the length of stay.
I have a couple questions here from chat. What pointers would you use in counseling patients on difference in health span and lifespan? Really good question.
So I think the first thing to do is elicit what so health span being, that's basically what the patient prioritizes over time, right? And if a patient's going to prioritize independent living, that would be one thing. If a patient's going to prioritize like mental function, if they say, look, I really, I had a friend and this was their result after surgery, I really want to maintain my med. So I think you have to get from the patient what they value. And you can see by those New England Journal, there's that New England Journal article that says that 70% of folks value function over lifespan, over longevity. So I think it's going after what that patient wants. And then you have to kind of understand the natural history of, if you do that big GYN oncology operation, what's the chances that they're going to be in a nursing home? And the person who's got really nice stuff out about that is Tom Gill, Gill, and it's in, he keeps publishing surgical literature, but he's got an amazing data set where he follows after operations the function of older adults, because they call them every month and measure their activity of daily living. But then you can tell them that trajectory. And then ultimately, I believe that the patient can kind of see whether it's worth spending 3 months in a nursing home or something if they can get back on their feet again. It's where they can't get living independently again. I think that's what really sticks up folks.
It's nice when we have the luxury of being able to prepare our patients for elective surgeries, or 85 years and older. You kind of listed the things that we should be thinking about. What about that more emergent surgery? Is there one or two things you really would absolutely look at?
Well, so on the emergent cases, so if you do the geriatric surgery verification program, so I'm going to kind of blend that with what we do here. I think it's very important, because a lot of ours are ending up on ventilators afterwards. And so it's very important to have what we call an MDPOA, but who's going to speak for that patient's values after the operation? Because what happens is the elective sort of flow, where you have this frail assessment, and then you have a multidisciplinary decision-making team, right? All of that kind of goes by the wayside when you're getting somebody in the operating room within 4 to 6 hours, kind of to save their life, right? This is a life or limb for an emergent operation. And so to do that, you sort of then all of a sudden you're trying to piece together the frail assessment on post-op day 1. But the rules are, by the geriatric surgery verification program, is within 48 hours of that operation, you should be in that room identifying what the advanced directives are, what the goal, did the patient want to be on a ventilator, what are their thoughts on pressors? And the key to that, I think, is before the operation, recognizing who that MDPOA is, so that you have that person to be talking to and having a meaningful interaction. And then you kind of piece together, were they frail? But at this point, that's not as critical, because you've kind of already made that decision. Now you're doing those supportive measures after surgery.
Sure. Carrie, do you want to say something? Are you still on?
Oh yeah, I'm here. I just wanted to add, because we've had over the past several weeks different communication workshops with the GYN oncology fellows and then the residents. And one of the things that I think really ties in well to the conversation now is this idea of, when you ask patients what they want you to do, the historical viewpoint on that has really been focused on interventions. So do you want to be DNR? Do you want to have this surgery? Do you want to have this chemotherapy? And I think this is an excellent way to highlight the difference between focusing on the values of the patients and then aligning the interventions to match them, versus focusing the conversation on the intervention. That, to me, sort of gets to this whole health span versus lifespan things. And since I want to just take the opportunity to sort of reinforce that point to those who have been through those workshops before and have heard me say it in the past.
Thanks, Carrie. Tom, Carrie is she's a GYN oncologist and is our residency director as well.
Nice to meet you. But I think that's spot on. We need to move from the strictly disease-focused counseling to more whole patient counseling. I mean, that is spot on what you said, Carrie.
And thank you, Tom, for your talk today. I think it's been really, really informative and helpful.
Any other questions out there? Any residents or fellows? Looking around, I see a lot of names.
We had one more quick question. What are your thoughts, Tom, on perioperative Toradol for acute use in the 85, 80-year-old and over. Do you have any thoughts on that?
So Toradol is on the beers list, so let's be very clear. It's on the list of what you should not take. But for short, we do it for 48 hours.
Okay.
We do 15 million. I mean, yeah. So we do a little bit. We don't do the higher dose.
Yeah.
But we 100% we use non-steroidals because I think what we want to be doing and achieving is, right. We want to do our regional blocks, our ice packs, all this kind of stuff. Tylenol's on everybody. It's like a standing dose. And then we start bumping up to the non-steroidals, which in this case is just a strong one, and ultimately oxycodone. But we 100% are doing it here. A little always reluctant to say stuff like that because theoretically, it's not like it's not FDA approved, but it's on the beers list. And so you should be careful. Don't let them go home on that non-steroidal. You know how medications in the hospital tend to run on, Pat? You got to like watch that med and hold it because you shouldn't give it chronically. I think you should absolutely be giving non-steroidals in the immediate perioperative setting.
Tom, again, thank you so much for this talk today. It got me pumped up again. I think it got others pumped up about approaches that we should be thinking about with all of our patients. So thank you again very much for being with us today.
Thank you. It's nice to be here. Thanks, Holly. Good to see you.
All righty. Good to see you. Bye-bye.
I believe we have an announcement. I don't know if they're on the line.
Hey, we're here. This is John with Office Patient Experience.
Well, you can go ahead. You're ready.
Go ahead. Thank you. Thank you. I'm just going to run through some quick slides if that's okay.
Yeah, that's fine.
All right. Can everybody see my screen?
Yes.
Good deal. So good afternoon, everybody. Thank you for allowing us to come share today at your meeting about some of the changes we're making with the way we survey patients at UAB. I guess the first big announcement, if you haven't heard, is Press Ganey is no longer a vendor at UAB. We removed all of their patient experience services at the end of September, and we have been working hard to contract with a new company and get everything set up called Medallia. And one of the reasons we removed Press Ganey, or a lot of reasons, is they haven't innovated their platform ever. The ability to customize questions and be innovative and do things that we want to do as a health system just didn't exist with them. So with Medallia, they're a company that's worked in the consumer experience arena for many years. They're partnered with big companies like Bank of America, Disney, Apple, Google, Amazon, and they entered the healthcare arena last year. So they reached out, contacted us. We looked at their product, and it seemed to check all the boxes that we were looking for, talking to everybody and patients on what they wanted to see. The big thing was increasing the real-time data collection, not waiting on a mailed survey to be returned, increasing response rates, reducing the burden, and creating frontline ownership. So partnering with physicians, providers, frontline staff, leadership on what do they want the program to do, what do they want to get from it, and those type of things versus Press Ganey, where it was more of just a push. It was what they had, and that was pretty much all we had as an option. So with Medallia, the real-time feedback is a reality now. So instead of emailing or mailing a paper survey to patients, we're actually sending SMS text messages. And it's not just a link that they can go to, it's an actual conversation within the text message. So patients can reply directly in the text message with their survey responses. As soon as they reply, the feedback automatically goes into the platform to be visible. So there's no lag time as far as that goes. Another big bonus is they have a natural language processor and artificial intelligence. So no longer do you have to manually read all of your comments to kind of see what patients are saying. Their engine will pull out themes, multiple themes from a single comment, as well as kind of rate those themes with the sentiment around those comments. So you can quickly see, what are the positive themes that patients are saying and what do we need to work on. I will say that we went live with ambulatory last week as far as feeding patients to the system. We're still in the process of testing it, but so far 3,000 is responsive. The feedback is overwhelmingly positive. We use a net promoter score, which is a little different than the overall rate 0 to 10 if you're used to that. So we're taking the 9s and 10s and subtracting the 0 through 6s on what they rate us. The 7s and 8s are neutral. And our average score right now is a 93. So it is super high, and our patients continue to respond in a positive manner, much more so, it seems, than Press Ganey. Another bonus of the tool is anticipating needs and predicting behavior. So with Press Ganey, we ask the same questions over and over and over again for years. This system will allow us to develop themes as a health system that are coming out, and we'll be able to tailor questions to dig deeper into those themes. So we can actually do process improvement with this instead of just using the same questions trying to figure out what's going on. Yet another bonus of going with Medallia is instead of being a follower and just using what everybody else is using, we are the 5th health system in the nation to go live with Medallia. So we join with the VA, Northwestern, Atrium, and Banner to launch this program and help innovate healthcare for the nation. This is just a quick slide on how the NPS score is broken down. It's just, like I said, taking the promoters, subtracting the detractors, and then the people who rate us 7 and 8 are considered neutral. The goal with the NPS score is to move those neutral people to a promoter. They consider detractors people who have already had such a bad experience that they're likely to opt out of future healthcare or visiting the institution. And you'll spend 3 to 4 times as much time trying to win a detractor as you would just moving a passive to a promoter. This is just a quick look of the conversation piece. As you can see, it's an interactive text message for the patients. We're only asking 4 questions right now on the SMS text. It's mainly rate the provider, rate the facility, and then just sharing any additional comments that they'd like to share with us. So it's short, easy, quick, and so far our average response rate for everything that's live is around 46%. With Press Ganey, the email survey, we average 16 to 17% response rate. So tripling the response rate just in the short time we've gone live is very encouraging, and we hope to continue to see this. There is also an email component to the survey. We're hoping to sample 60% SMS, 40% email. And the email surveys just allow us to capture a few extra questions about the physician provider, the facility, scheduling, cleanliness, and those typical things that we used to look at. Here's just another quick example of how the SMS survey is laid out. Patients respond on a 0 to 10 scale, and then they can leave their comment at the end. And this is how the text analytics platform will look. You can quickly log in. Hopefully in the next year, we'll get it set up to where individual physician providers can log into the system and immediately see just their data. They can see the common thematic analysis among their comments as well as how they're scoring. And of course, that'll be optional if you want it or not. We're looking at hopefully developing some standardized reports if anybody's interested in seeing those. These were the 4 questions I talked about. It's just really quick, simple, and the response rate is showing that patients are liking it. That was one of the big comments we got on the Press Ganey survey is patients absolutely hated the survey. It was 75 questions long, and I myself believed it was ridiculous, and patients, of course, agreed with that sentiment. These are the questions on the email survey that are going to be asked of the provider. It's just going to ask if we listened to their needs, gave clear instructions, showed empathy, showed friendliness and professionalism. We do have a data governance committee that we've set up. It does include multiple physicians on it. These are just the first questions that Medallia suggested to go live with. Over the next year, we'll be working collaboratively to make sure these are the right questions, and if not, what do we need to be asking? And we really want this to be a collaborative process so everyone feels involved with it and that everyone feels okay with what we're doing. We don't want this to just be a push from the top down. We want everybody to feel a part of this and understand the data and like what they're seeing. And Travis, did you have any additional comments you wanted to add?
I was just going to say the invitations for the survey go out at 9 a.m. the next following morning after the arrived visit. And within the first 24 hours, we're over 40% response rate. And within 48 hours, it's at that 45, 46% response rate, which the lag time on that is almost immediate versus around 2.5 months, which was the previous data. So this data is relevant. It's easy to make corrections or to show improvement quickly and not just waiting 2.5 months for something that, you know, if there was an issue, was either found by somebody else or has become a huge issue because it has happened for 3 months. So this data is much more important, much easier, more real time. So it's going to be easier to absorb and make changes if there's any changes needed. And like John said, this is something that, you know, we want everyone invested in, but the questions can change and be independent depending on what area, what clinic. So I think it's a good move that's really going to show more of what the patients are feeling instead of a standard 75 question survey that no one really wants to answer. We're actually getting that 45% doesn't only include the people that feel strongly one way or another, but your people that are returning all the time that love UAB and love to come to UAB because it is UAB and the provider, the service that they get and the care that they get. So.
Yeah, another bonus of the system is there is two-way capability communication with the patients. So if they do leave a comment that they're needing help or having any issues, we do have it set up to where the clinic manager or director will get an alert from that patient and they'll be able to reply directly to the patient. So our hope is to hopefully offload some of those portal messages where patients have an issue. And previously, when they get a survey and send a reply, it depended on us pulling monthly comments and sending them out, which by that time the patient's probably already portal messaged you 3 or 4 times. So that's another bonus of this platform is to hopefully reduce that portal message load. If a patient just has a simple issue, we can solve through email. And that was all. Does anybody have any questions about the platform or anything they want to know? All right. We're always here if you have any questions. You can just shoot me an email at jm.@uabmc.edu. And if you can think of anything or would like to be a part of anything, just let us know.
Can I ask a quick question? Is it going to be done on inpatients as well?
No, the inpatients, unfortunately, the CMS rules, we have to survey them with an HCAP survey. We have swapped to a company called J.L. Morgan from Prescaney. They're a local Birmingham company. And we will be using phones, a direct person calling the patient to survey them instead of a paper survey. So we will get that feedback much sooner with the J.L. Morgan product than we did with Prescaney. But in the future, the possibility of using Medallia on inpatients is there. They do have the ability to, say, text a patient as soon as they are admitted to a unit and ask them some questions. It'll just be something we explore as we implement this program.
Thanks.
No problem. All right. Well, we thank everybody for their time and hope you have a good rest of the day and a great weekend. Thanks. No problem. Bye.